My name is Barry Smith. I run the Clinical Skills Unit at the Admiral's Hospital for the Clinical School. There's my colleague here.
Hi, good morning. I'm James Watling, the Clinical Skills Manager here at the West Suffolk Hospital.
James and I have worked together for many years, and we both have experience in placing small peripheral lines, but some of the more advanced lines, things like PICC lines and things, which we're going to talk to you a bit later on. But really, this session is, it's not a big academic session. We have a wealth of experience that we want to share with you. And if I could just use one example, if you imagine, here's this line here, okay, it's got 5 lumens, and you may well see a patient that's sort of wrapped around their neck. And it's the tip of the iceberg. What's all this lot doing in here? How did it get there? Why did we put it in? And then there are other variations to some of these lines. Okay? And what we want to do is take you in a logical, sequential steps, looking at peripheral access to these things which we refer to as central lines. Okay? Thank you. So I think, first things first, I'm going to talk to you about, we are going to talk to you about peripheral access and the major problems. With all lines, infection is a potential problem. So aseptic no-touch technique and exceptional aseptic technique at all times. But there's another problem that we have with lines, particularly peripheral lines, which is phlebitis. Do you still use the phlebitis score?
Yeah, VLP score. Yeah.
And so what's the process here for the nurses?
So our nurses on a shift-by-shift basis will complete a VIP score for every line that they've got, just so that they're surveying it, observing it and acting appropriately, so that we deal with the issues before they become a significant problem to the patient.
And I'm expecting, so what are they looking for? I mean, we're looking for a line to last maybe 3 or 4 days, aren't we? So I remember sort of redness, erythema, what else?
Yeah, so there's kind of induration, discomfort, discharge, symptoms that the patient may report, pain, tenderness on injection. I think it's really just a very good but basic overview of how healthy the vein is with the device in situ.
And I think it's probably fair to say that the VIP score is done in every hospital, but it will be slightly policy driven by different hospitals, may have different sort of criteria, but it will feature. It is of interest to you because as entries into the medical profession at the sort of junior level, you run the chance of it's you that's going to be asked to come and replace cannulas that have failed, and they will have failed because of phlebitis. So what we've arranged here, we've got some peripheral cannulas here. We've got very small 24 gauge going right up to 14 gauge, and we'll talk you through those sizes. We've got some needle-free access devices to go on the end. And then as we progress up, we've got what we call midlines and short lines here that are just like long peripheral access devices. And then we've got here, we're going to talk you through PICC lines, peripherally inserted central catheters. And then we have got a central line here, the one I've just showed you earlier on, that is an internal jugular line. We've got a Hickman line, which goes in subclavian, okay, but we would actually tunnel it away from the site, okay, and we use a tunneling device. We can use another device into the subclavian, which is called a portacath. Okay. So we've got a range of these things we're going to run you through and actually look at some insertion options. So we use a thing called Seldinger technique, where we use a guide wire. And for particularly those who are going to go down the careers in cardiology or interventional radiology, this is a bread and butter thing. You put a needle into a vein, you put a wire into the needle, you can then put a dilator, a catheter, anything over the top. We also use it for some chest drains. We also might use an ECG electrode to help place a line. So there we're going to look at how you place lines and at the different lines. But what I want to do is start at the very beginning and just discuss phlebitis. So what I want to do is to talk you through phlebitis and the problems that it causes and how we can mediate or mitigate against some of these happening. And I apologise for the amateur audio-visual aids. I'm the audio and this is the visual. So we're going to put these two together and just explain it. So simple thing, but that's the skin, there's a vein running in there, and I put my cannula in for the argument's sake. This is a green cannula, I get it into the vein, okay, and I get my cannula in the vein, and I'm now going to give a particular drug through there in the moment. But what's happening in the vein is clearly blood is flowing along the vein. It comes around the cannula, and the effect of the blood is to actually cushion the cannula against the inside of the interior of the vein to stop it rubbing. If the cannula is quite large or there's angular changes in the anatomy, the cannula can rub on the vein and cause what we call friction or mechanical phlebitis. But for now, we'll just assume we've got the cannula in and we've got a blood flow running along here. Okay. We then give a drug, I show it to pens here, this is a red drug, but the drug's going to come out at the end. If there's any pH gradient difference between the circulating blood and the pH of the interior of the vein, there will be a small reaction here, and that gives rise to what we call chemical phlebitis. When chemical phlebitis happens, the interior of the vein becomes inflamed, and this inflammation is intraluminal, so the internal diameter of the vein reduces down. And so what happens is, we're giving the red drug here, we rely on the fact that the blood comes along here and it dilutes at the tip. If we get ineffective hemodilution because the cannula is too large and we reduce the blood flow, what then happens is the vein here becomes irritated on the inside. And so it starts off becoming, maybe for the patient's experience, will it be sore when the drug is administered? It may actually become sore when the drug isn't being administered, and it becomes red and painful, and there may be a discharge. And so what's happening is we're losing the internal diameter, is collapsing down because the inadequate blood supply and the inadequate hemodilution. Because of that, we then start to, the tip of the cannula starts to rub on the irritated vein, and that compounds the problem, so we get a combination of mechanical phlebitis, friction phlebitis, okay, and obviously the narrowing that's going on here. And it just gets worse and worse. There's no way of stopping it once it happens, and eventually what will happen is the drug or the infusions we give will start to backtrack. They'll come out the entry wound, okay, out here. They'll leak out and they're under the dressing, and you may have blood there or you may have clear fluid. You also get edema because as the fluid leaks out, it tracks laterally along the tissue lines here, so we get that edema being formed. Effectively, the cannula has now failed. Euphemistically, it's sometimes described as a tissue cannula, but in actual fact, if you ask people to describe that, they'll say the cannula's come out of the vein, but actually what's happened, the cannula is nice and snug in the vein, but the vein is effectively blocked off, and we're leaking out into the tissues. Okay? So this cannula has failed. We would reasonably expect a cannula to last maybe for 3 to 4 days. It's not going to last if this happens, and therefore what we need to do is pick the right device for the right patient so we reduce the likelihood of this happening. Okay? The key to intravenous therapy ultimately is effective hemodilution. So James, we're going to look at peripheral cannulas, and we'll refer in a moment to a chart looking at flow rates and things.
Yeah.
Okay. So where should we begin?
Well, you know, obviously when you're on the ward, you've got this selection of cannulas, and we don't want their choice to be arbitrary. So I'm just thinking about a really common scenario. Maybe a patient is needing 3 times a day antibiotics, maybe for someone with cellulitis. If I were faced with that decision, where should I go cannula-wise?
I mean, first of all, you should only put a cannula in that you know you can get in.
Yeah.
Okay. But if we look at these cannulas here, we've got the sort of, you know, we're sort of down at the neonate range here. You've got the 24 gauge, you've got 22, you've got 20, you've got 18, 16, and 14.
Yeah.
So in this scenario, you're talking about a bit of rehydration and maybe flucloxacillin type thing. Then really, I'd be down here, one of these two. And even if we said the pink cannula, the 20 gauge cannula, this sort of cannula, you know, if you ask people, they look at it and you say, well, what's the flow rate through there? People come up with some wildly exaggerated responses or some quite small ones. But in actual fact, I know that this cannula could put about 60 mils through every minute. and it's under gravity. And I think it's probably reasonable to say at the moment that if I show you this package here, this is a cannula in a packet, all of the manufacturers will write down here, we can't show you this at home folks, but you can have a look at any one in your stores. It will actually put down the flow rate in mils per minute.
Yeah.
Okay? And there is an international standard for the flow rate, and the actual standard is that a distilled water at room temperature is held 1 metre above a device, it's allowed to flow through, and they measure the flow of 60 mils, and then from that they extrapolate the minute flow, the hourly flow, and the 24-hourly flow. So I know that what I'm talking about at 60 mils, this is more than adequate. Yeah. And so I know it can easily do the therapy that you've described, but it actually minimises the risk of phlebitis. If I was to pick one of these big cannulas, I could still give fluids and fluproxacillin, but the phlebitis is more likely to occur with that big device, and therefore I'm going to have to change it much sooner. So as far as I'm concerned, I would pick that. And maybe if somebody's got good veins, I'd still think the 22 gauge is a good call as well. Yeah. Any others?
Yeah, so now maybe something a little different. So you could be called to see a patient on a medical ward. They've had a report of some coffee ground vomit. Your end of the bedogram tells you that they look a bit shocked, a bit pale, maybe tachycardic. What kind of access would you be looking for in that situation?
Well, I'm heading up here and we're looking really, I would bypass green. I think that a green is often too big for routine use, but actually in many cases it's not big enough for serious fluid replacement. So I think for the coffee ground patient, I'd certainly be down probably looking at maybe a 16 gauge cannula. Okay, it's bigger, it needs to go into a bigger vein, but I think the important thing, and obviously I can do a fluid challenge and other things for there, but I think the important thing is that in normal routine therapy, we're thinking about making the cannula last for a few days because we're very busy people. We don't want to keep going around changing devices. And if a cannula does fail, there's a lot of evidence to show that patients actually miss their next incremental dose. So if somebody's on antibiotics for a week, they miss certain doses, which prolongs their inpatient time and delays their therapy. So I want the cannulas to last as long as they should. I know if I pick a small cannula, that will work. When it comes to big cannulas, like the patient with the GI bleed you're describing, the coffee ground, or obstetric patients, perioperative or trauma, I am not too bothered whether that cannula lasts another couple of days. If this one buys me time, because I can put fluids in rapidly to keep them alive, and it only lasts till tea time, I don't mind, because I've got time to do things. But for the here and now, I need to go up a size to get fluids in. Okay? But this will have a shorter dwell time, but that doesn't matter. And so that's a 16 gauge and 14 gauge, which is routinely the largest one that we would use in practice. And can we just look at, we've got the chart here, if we can actually just look at the flow rates?
Yeah. Okay, so we're just looking at the chart now with the cannula sizes. Down the first column you can see the size of the cannula, and then we can look at the colour. These are all international standard colour coded, so your blue for 22 gauge example, the pink 20 gauge that we've just now talked about in our prior situation, 18 gauge being green, 16 gauge being grey, and the largest in pretty typical use, the 14 gauge being in orange. Now if we think back to our 20 gauge cannula that we considered just a moment ago, that device is capable of 60 mils per minute, just under gravity. If you were to put it through some kind of infusion pump or even pressure infuse it, you can look to triple those values, so we're looking then at up to 180 mils per minute. Now that obviously is a significant amount of fluid, and if you extrapolate that up to the fluid that would be absorbed into the patient's circulation in the hour, that's 3.6 litres of fluid just under gravity, just with the drip that's hanging up with the drip chamber wide open. And again, if we do the maths and take that up to 24 hours of time, we can look at a phenomenal 86 litres of fluid could be absorbed through that device, and clearly that's far in excess of our patient who's sitting on the ward needing some intravenous antibiotics and maybe some background hydration. If we also consider the point that Barry very decently raised about the differences between the 18 and the 16 gauge cannulas, physically there's not really a significant difference to them from your perspective, the clinician citing them. If you can pop an 18 gauge in, then almost always you're able to get a 16 gauge in. But in those situations where you need aggressive fluid resuscitation or boluses of fluid putting in very quickly, you can see that the 16 gauge is many times better than the 18 gauge for that, with its flow rate per minute being 200 mils per minute versus the green cannula, the 18 gauge, is 95 mils per minute. So I think if you are faced with that situation where you need to establish access for the purpose of fluid resuscitation and also for the rapid administration of solutions that are perhaps more viscous, blood components, etc., then you're probably wise to look at going for the slightly larger 16 gauge. I think it will give you a lot more in practice.
Okay. James, thank you very much for explaining the flow through the chart. If I can just remind you that when it's the actual flow rates are inversely proportional to the diameter, so the and to the length. So the longer the cannula, irrespective of the diameter, the flow rate decreases. So we need to remember that about these devices. The one thing I want you to look at these, they do not have a port. So the way we administer the drug, we're not going to plug the syringe in the back here. What we're going to do is put a lure fitting on. In this particular one, we've got two fittings on the end. So the syringe will plug into the end of here, and the fitting goes onto the cannula. So as a way of reducing infection and mechanical phlebitis, we want all of the manipulations that the doctor or nurse carries out with giving injections or fluids to be away from the insertion site. So we've got a sterile, vapor permeable, clear dressing so we can see for phlebitis over the cannula, and all of our actions are done remotely, a few centimetres away. It would be right to tell you, to explain, you will be familiar with what we call ported cannulas, and that would be a cannula, for example, look at the pink one here, where we can actually give the injection through the top port. The reason we don't use these all the time is we can't actually clean inside the port, so the risk of infection is quite high for these devices. So they tend to be restricted to be used in anaesthetics, where they're used for a few hours where the anaesthetist is giving incremental drugs, or they're used in places like endoscopy suites where the patient needs sedation and possibly another injection. But in both those cases, they're not intending to leave the cannula in for a long period of time. So we can use this one, and it's actually cost effective because we can use that sterile hub before it gets dirty for a few hours. If we then start to add something on the end, these devices are all in the £2, £2.40 range, so there's a cost element to it. So short term we can use a port, and in longer term we use non-ported. While I've got this in my hand here, I just want to show you all cannulas, according to EU law, have to have a mechanical safety device. So I've showed you this one. This has still got the needle in. As I withdraw, you've got a sharp needle at the tip, but as I withdraw the needle, okay, and it starts to come out, the needle is now into that little shield there. Okay, it's now protected. I can't give an accidental needle stick injury once I've withdrawn this. Okay, and all of these cannulas would have the same. So then if I put it alongside this pink cannula, they're actually, the cannula itself is the same length, same diameter, has the same flow rates, but this one requires an extension, and this one I can inject through the top. So far we've been talking about peripheral access. So if you think here's somebody's arm, we've been putting in cannulas lower down here. And if you think of an average adult, if you put a cannula into the back of his or her hand, you would be looking at maybe 30 or 40 mils of blood flow per minute. So there's limited options for hemodilution. And remember, hemodilution is everything. If we can put in a device higher up, we get better flow rates, and therefore we get better hemodilution. So we can put what we call long lines in here. We can get a line up to here into the basilic vein or the cephalic, although the basilic is easier to insert. And we have these devices called long lines or mid lines where the tip is here and we get better flow rates and hemodilution. Right? Or we can go higher up and we can have what we call a PICC line, peripherally inserted central catheter, which will go in and go round into the vena cava. Although it's inserted peripherally, it becomes a central line. And by central, we mean it's into one of the central veins, either the superior vena cava outside the right atrium, or it could be the inferior vena cava outside the right atrium at the sort of junction here. We can put the line in, as I've said, peripherally and all the way around. We can put a line in the internal jugular vein, be a lot shorter, but it ends here, or we can put a line in one of the subclavians to get to here. The key point about central line is where the tip ends up, not where it went in. And there are many ways of getting a line in there: femoral, subclavian, internal jugular, or a peripheral vein. Right? Now what I'm going to do, if I just show you now what the flow rates are, look at this image now. If we were to get a midline into the basilic vein, you can see already the blood flow rate is 200 mils. The hemodilution is already better at this point. And as we progress up to the lines in the subclavian, it's already between a litre and a litre and a half of blood, depending on the age and the gender of the patient. By the time we get round into the central area where we want to place our line, we are looking here at an amazing 2 to 2.5 litres per minute. So if you think of the causes of phlebitis, the irritation, the pH gradient of drugs, some drugs, and you would clearly have to consult the pharmacist at some time or experienced colleagues how you choose it. Some drugs have to be given centrally because they're so irritant, but we maximise hemodilution here, so we're not going to get chemical phlebitis at this point, because whatever we give will be given and diluted rapidly and dissipated systemically around the patient. So if I can just repeat the point, if we get a line here, it is central, but it doesn't matter where we put it in, okay, it's where the tip ends up. So what I'm now going to do is James and I are now going to work with the devices and show you all the different devices that we use that are going. These sort of lines here. We've got another Dacron cuff on here, but this is a Groschon Hickman, and it's got the Groschon valve here, just the same as we had in the PICC line. Okay, remember it's the tip position, so it's got the Dacron graft, so it will granulate out, and the patient will not need a dressing over there. But this line can be placed remotely. And the last line I want to show you, if we think about being remote from the entry wound, we can also tunnel out, and this is called a port, an implantable port. You place the line, subclavian, you tunnel it out, but this time we place this port, this little mushroom thing, under the skin, and it will sit under the skin with nothing external out there, and we would access this line using a thing called a Huber needle. Okay? And what would actually happen is this needle is then inserted through the skin and into the vessel. We can then flush it, take blood samples, give medication, okay? But it's implanted, and therefore it's a lower infection risk. In this country, it's frequently used in paediatrics, particularly in the oncology setting, but in continental Europe, particularly in France and Germany, these are very popular for adult oncology, and they use more of these and fewer PICC lines and fewer Hickman lines. So we've got this mannequin here called chest to chest, and he's got lines in all the various places. So if I can start again, and we look at the multiluminal line that's going to go in the internal jugular, it demonstrates it here. You can see the line. So this line would have been placed internal jugular, but you can see where the tip is going to be, SVC. Okay, and it's already in position there. This one here is a peripherally inserted central catheter. Okay, and so that could be this PICC line here. And remember, the tip is going to be here in the SVC, and it's come in the arm here. And because this one is a bit longer and the mannequin is quite small, you can see we would have trimmed this line in order to get, where's the tip? The tip is SVC. Okay. And then here we've got tunnel line. You can just see in relief here a demonstration of the tunneling. So it's over the sort of subcutaneous fat, it's under there, and it comes out here. You can see how remote it is now from the position it's in the SVC, but it's been tunnelled out of here. We could still trim it, okay, but it's been tunnelled out, and therefore we're not close to where the patient's got their airway, their tracheostomy, their tube, any vomit or any saliva, or any moisture here that makes infection more likely. And remember all the time that the patient is having treatment here, if the nurse is flushing, giving drugs and so on, they are going to potentially cause an infection. So we want to keep away from those areas of activity. Okay, so that's our tunnelled Hickman line. Okay. And the port, if I was to put a port in place, these can be sighted really at present, but again, that's another line here. It's centrally placed, but the port might well be under the chest or under the side here. You need to get good access to it, but we've kept away from the airway. So what we're going to do, they're the positions that we look at. Okay, so midlines and PICC lines can be here or the antecubital fossa. Peripheral lines clearly further down the arm. Internal jugular placement, subclavian placement, which can either be sitting there or, as we have on this occasion, we've tunnelled the line out. So what we're now going to do is specifically look at the insertion techniques. So we're looking at the use of ultrasound and using what we call the Seldinger technique. It's the actual way we get into these veins. Okay.
So when we are thinking about the Seldinger technique that's going to be applicable in a range of line insertion, the first thing that we're going to consider is the accessing of the vein with a needle, often performed under ultrasound guidance. We're going to talk about that in a moment. Once you've accessed the vein and you've got an active drop of blood coming out of the end of the needle here, you'd expect to find a steady drop, drop, drop of blood. You're then going to introduce the atraumatic wire into the needle and subsequently into the vein. At this point you can steady the wire and remove the needle so that the wire, the guide wire, is now left within the vessel. At this point you may need to make a small incision at the skin just to give yourself 1 or 2 millimeters of incision to make way for the split sheath dilator, or you may not need to. We would then pass the split sheath dilator over the wire. The key thing is not to let go of the wire at both ends at the same time, so always have a hold on to the wire, and then we would simply use the guide wire to railroad and to guide the split sheath dilating introducer into the vessel to the full length, and at that point the guide wire can be removed. You would then steady the split sheath, peelable sheath, and remove the dilator from it. you're now going to see a constant flow of venous blood coming out of the end of the sheath. And then we would insert the catheter through the sheath into the vessel to the full length, using any ECG technology, etc., to take it to the desired tip position, which is going to be, as we said earlier, in the superior vena cava. And then at this point, we simply break the sheath, being mindful of blood splash, and just peel it apart and advance the catheter. Peel it again, advance the catheter. Peel it again, leaving just the catheter within the vein, within the arm, ready for imaging and flushing and aspiration of blood to confirm its location. The use of bedside ultrasound to assist with vascular access is becoming far more commonplace. Not only does it allow you to locate suitable veins which would otherwise remain hidden, it also allows detailed assessment of the vessels to be performed prior to access with the needle. In the case of thrombosed or sclerosed vessels, it can avoid uncomfortable and ultimately futile attempts being made. Gentle downward pressure is applied using the ultrasound probe. If the vessel partially flattens and continues to pulsate, then it is highly likely to be an artery. If the vessel completely flattens under gentle pressure, it is likely to be a vein. If the vessel fails to flatten and simply moves downward as a result of the gentle pressure being applied using the probe, it can be suggestive of thrombosis. This can be further assessed by use of the gain setting. In the next image, you will see a demonstration with repeated compression using the probe to achieve complete flattening of the vessel with no pulsation, indicating that the structure being scanned is venous.
So, James, right, I hope you guys found it useful. We've got some experience here, and we just wanted to do a brief whistle-stop tour of intravenous access, peripheral access up to central lines and how they work, and the different sorts. This is not meant to be an exhaustive academic exercise. We just wanted to prepare you for your first job, which you're taking on. James, anything we need to mention about policies?
Yeah, I think so. Just to be aware that we all work in different establishments with different policies and guidance, and of course you should always adhere to that and follow the recommendations of your employing organisation.
Yeah, and I think the sort of thing I know that crops up every now and then is that you're tasked sometimes with having to get blood. There are some organisations where you'd be allowed to take blood from the PICC line, and other places you would not be allowed to do it. And the risk of blocking these lines, which are sometimes very difficult to put in, sometimes very expensive, the risk of blocking them in order to just get a 50p blood test is not viewed very positively. So just be aware of the constraints by which you operate. And as with all of these things, if you're not sure, ask somebody. Okay. So I hope you found it useful. What do you think, James?
Thank you very much for listening.
Yeah, thanks for listening. We're on tour. Okay, thank you very much, and good luck on your future careers.